I'm so happy to be able to talk with you today. My name is Rachel Golden. I'm a clinical psychologist at Columbia University, and I'm really excited to talk to you about LGBTQ cultural competency, particularly as it relates to transgender and non-binary adolescents. So here are the disclosures for this project, and I'm moving along. Our objective today is for you to gain an understanding about the experiences of transgender and non-binary adolescents, to gain some understanding about experiences impacting wellness and adherence to HIV prevention and care, to increase intersectional thinking and apply some techniques, not necessarily therapeutic techniques, but just some gender-affirming techniques and creative ways to reduce barriers to care in your setting. I hope you understand by the end of this that targeted care can be really useful, and that creativity in how you do things and modification of what you're doing already is really necessary as well, and that intersectionality is really critical to take into account when you're giving care to this group. So, welcome. I want to introduce myself and locate myself first. I am not a transgender person. I am cisgender. Which means that the sex that I was assigned at birth aligns with the gender I know myself to be. So, it can seem kind of funny that I would be presenting on this topic. I care really deeply about creating equity within healthcare and therapeutic settings for transgender and non-binary adolescents and individuals. And my goal is to try to talk with you about a provider's role and not to talk with you about first-person experience of being transgender, because that's not something I would be able to do. I don't know if people have done this before, but I'm going to introduce myself as well, saying that I use she, her pronouns. This is something that can help you to affirm people when you're meeting them for the first time in your setting, to just say, what pronouns do you use? I use she, her, I use he, him. I use they, them, or ze, them, if you've heard of those before, and then a person can feel free to let you know what their pronouns are as well. Has anyone had an experience of doing that with a patient yet? Maybe not. Okay, it'll be a great challenge for people to do in the future.
Somebody said yes, we had you on mute.
Oh, I'm so sorry, it's so hard to hear. Maybe moving the microphone closer would help.
Or unmuting it helps too, so it's unmuted now.
Oh, that's a great idea. Perfect. So have people had experiences with this, with introducing themselves using pronouns?
Yes.
That's great. How did it go?
It was fine.
Yeah. And it can, one of the things that I like to remind people is that using pronouns can just be really important. We use pronouns automatically to try to validate who a person is and try to validate their experience. Doing the mental gymnastics of rearranging how you are thinking through using pronouns and actually using correct pronouns with someone can really create a warm and welcoming experience for them in your setting. All right, so let's talk a little bit about identities. A lot of the times when we're talking about gender identity, these other things come up as well. So we talk a lot about sex. Sex is a classification that is made by a doctor when you're born, or a midwife. They look at the parts, the external sex parts you have, and they say, this is a male or this is a female person. There are individuals who don't necessarily fit the dichotomous male-female definitions of sex. These people fall under a category called intersex. And that's important as well to recognize that we don't just have male and female sex folks in the human experience. Gender identity is what we're going to talk about more today. It really is how somebody identifies internally. It's nothing that anyone can tell you that you are. It's not something that somebody can tell by looking at you. It really is how you identify internally along a continuum of identity that we think of as being anchored by between being a man and being a woman. Gender expression is how you dress, how you do your hair, how you manifest and show your gender to other people. Sometimes people think about it as behavior and mannerisms as well. And sexual orientation identity is whom you choose to have sex with or who you choose to become sexually or romantically attracted to. And all of these things are really important when we're talking about gender identity, because a lot of the times they get confused or conflated. And they also are other important aspects of identity that aren't necessarily encompassed by gender identity in and of itself. So here are some binary gender definitions, and binary being like 1-0 coding. So you can see that we have transgender, an individual whose assigned sex does not match their gender identity. We have cisgender, someone whose gender identity does match their assigned sex. We have trans male, a transgender person assigned female at birth. So when they were born, the doctor looked at them and said, you're a female. But when they came to know their own gender, they knew that inside they knew their gender to be male. And trans female, which would be the opposite. One thing to know is that there's no ED at the end. We don't say transgendered because these are adjectives, not verbs. So, you know, you would be talking about a transgender woman, a transgender man, or a cisgender woman or man. And there are two great examples here of Janet Mock, who's somebody who, if people want to go and hear about intersectional experience in being a transgender woman of color, this book, Redefining Realness, is a wonderful resource. And then the gentleman listed below is a trans man who is in Germany and who tried out or wrote in and to become one of the cover, I guess, models of Men's Health, and ended up winning as the audience selected person to be on the cover, and he was photographed later. So that's a nice bit of transgender recognition in Germany. People also have non-binary gender identities that they fall under. Non-binary gender, NB, is a gender identity that doesn't necessarily fit within the male and female idea man and woman idea of gender. So it's non-binary, it's somewhere in between. People also sometimes refer to themselves as gender fluid, meaning that your gender may vary over time or even across the day. You may have even a combination of identities that you experience. Gender queer is somebody who doesn't necessarily ascribe to conventional gender distinctions. They may identify as transgender, they may not, and they may identify as having either, both, or a combination of male and female gender. And then neutral also encompasses neutral gender, agender, null gender, neither male nor female. There's no one definition. It's just a category that people have found more empowering to describe something that we can't really define yet with science. It's just sort of understanding gender in a novel way. And if anybody watches Billions, you can see Asia Kate Dillon. They are one of the leads on the show and actually get to play a non-binary character, which is really wonderful for representation as well. Has anybody ever seen the gender unicorn before?
Yes.
Yes.
Or the genderbread person?
Yes.
Yes. So a little bit of history on that. So the gender unicorn was created by trans students. The genderbread person is something that actually a cis person took from a trans person on the internet and created. So we try to be very intentional. I try to be very intentional to use the gender unicorn, which was created by trans students and is a little more expansive and talking about these different aspects of identity. So obviously you can see here gender identity, gender expression, sex assigned at birth, whom you're physically and emotionally attracted to. Now, what you want to think about is that these are all different categories and different experiences. And the way you might start talking with someone, if you were in the position of talking with them about their gender identity, would be to say, you know, if this point on the bottom right here is 0 and over here is about 100, what part of your experience do you experience as a female, woman, or a girl? And somebody might mark that they experience no portion of themselves as a female, woman, or girl, a large portion of themselves as male, man, or boy, and some other portion as other genders. I actually had a patient say to me once, he had started taking testosterone and he was feeling very validated, and we were talking about his gender identity, and he said, I know that there's no part of me that's female. So he was a trans male. And he said, I think I'm about like 85% male. And then he said, but the rest of me, it's sort of like water. It's like 85% H2O and 15% other minerals. And so a lot of people are sort of coming up with new and novel ways to describe this experience to people, saying that, you know, it's not that I just fit on this binary, I fit somewhere else as well, something that we haven't really come to define yet. You know, gender expression can be mapped the same way. So feminine, masculine, other, and falling into those categories. Sex assigned at birth would be there. and then whom you're physically and emotionally attracted to would fall here. You know, it's, people can say like, I'm physically attracted to a little bit to women, somewhat to men, but, you know, much more to other genders. And these don't have to all add up to 100. You know, what we're looking at here is just ways that people can express how they're feeling, that aren't necessarily captured by binary gender boxes or, you know, metrics that we have that exist. WPATH is the World Professional Association for Transgender Health, and they're an extraordinary resource if you're starting to do gender care. They have issued the WPATH standards of care across the years, and now I think we're on version 8 will be coming out soon. What they say about gender is this: the expression of gender characteristics, including identities that aren't stereotypically associated with one's assigned sex at birth, is a common and culturally diverse human phenomenon. So it's not just happening in the US, it happens all over the world, and it shouldn't be judged as inherently pathological or negative. So it can sound a little bit like we're pushing for, you know, very new things that people don't understand quite yet. And so it can sound like it's easy to pathologize, but these are experiences that have been tracked across time and across cultures. This is certainly not unique to the US setting, and it's not unique to, it really is just a true part of the human experience. So we're going to talk just a little bit today about intersectionality, because whenever you're working with trans kids and non-binary kids or adolescents or individuals at all, you don't just want to consider their transgender identity as the driving force in what gets them from point A to point B in the morning. And a lot of the reasons why we do this is just that we know that people's experiences are intersectional. They carry around with them social identities as well as categories that they get placed in, where people are constantly judging them and coming up with ways to think about them based on how they're perceived or where they seem to fit in the way that society has classified people. And we'll talk about this a little more later, but with transgender individuals, you really see a lot of very intense marginalization. And that is further multiplied by racial and gender identities and sexual orientations, you know, where people are experiencing multiple marginalizations across their different identities that they have. So you really do want to consider the whole person and their experience in the world. A lot of times when we have talked about identities in the past, we've talked a lot about how they're not really intersecting. So it's sort of this idea of we all have this pie, and, you know, some portion of your identity is your gender identity, some portion is sexual orientation identity, some portion is your racial identity. And we've almost been pushed in the past into checking those boxes and thinking about them as being very separate, right? So you would end up with somebody who had these 3 very distinct, very separate identities that they held. What we're learning with intersectionality, which is a theory that was created in response to the feminist movement by Kimberly Crenshaw Williams and the, you know, Combahee River Collective Statement writers, that the way that identity works is that it's the simultaneous, the all-at-once operation of all these different identities in the life of a person. And so it's very different than what we see previously, this idea of like compositional diversity or the united colors of Benetton. It talks more about how the experience of these identities as they cross over and they intersect in someone's day-to-day and as they change across different settings. So let's talk a little bit about intersectionality. The first tenet is what we've already talked about. Individuals hold many social identities at the same time, and these identities interact to shape their experience. So for example, if you have an individual who identifies as trans female, a lesbian, and a Black African American woman in this case, you can see that there's overlap in how their identities function. It isn't that pie. You know, people don't necessarily generally experience themselves as just trans female, right? They're experiencing this confluence of identities across different settings. So you could take all of their identities together and think about it as this sort of beautiful rainbow of experience, which also will confer some things that are hard along with it, along with other things that are really wonderful and interesting to experience. So the second tenet of intersectionality is that identities are not considered uniform. And the way that we want to think about that is with trans adolescents in particular, is that somebody who is classified outwardly as female, maybe it's somebody's read of them on the street. Maybe it's how the doctor assigned them at birth and how the family has come to think about them. This identity that they hold really could be that they were assigned female at birth. And so yes, they hold this female identity that people read. But they could also be assigned male at birth and being read as female by other people. They could be gender non-binary and being read as female. They could be neutral and be read as female, etc. Agender, not having a gender, but people are still reading them as female. Or they could just have a feminine gender expression. They have long hair, they wear makeup, but maybe they themselves identify as male or something, or another gender that we've talked about. So the idea is that this experience, even though this person falls in this category, based on other people's judgment, the experience is likely not the same. Sorry, there we go. The third tenet of intersectionality is that having the same identity as someone else does not mean that you have the same history or present experience. And the way we can think about that is something that comes up with adolescence, and that we'll talk about a little later as well, adolescence and family acceptance. So adolescents who have accepting families do dramatically better than adolescents who have rejecting families. One of those reasons could be that the adolescent with an accepting family is able to have, more access to care, more access to medical care and support during that type of treatment and gender affirming environment that they're going to. They may be taken to that setting. Another adolescent who's transgender who does not have a supportive setting may be kicked out, right? They may be kicked out of their house. They may be living on the street. They may have to, exchange sex for money or drugs or housing or anything like that. So even though these people have the same transgender identity, they definitely do not have the same experience, right? And so we really want to look at people as having multiple issue lives, as Audre Lorde said. There are many things that are coming together, even within one identity. So the fourth tenet that we'll go through is that social identities that people hold obviously confer relative amounts of privilege or oppression depending on the context. So what we can say with our individual that we've talked about so far, the trans female, Black, African-American, lesbian woman, is that when she finds herself in a setting with other Black or African-American individuals, what may be more salient and whereas her Blackness, her experience of being African-American may feel more equalized across this setting, her experience of being a trans female and a lesbian may become more salient at that moment, and thus may confer less privilege to these two identities that stick out more. And then if you were to change the setting and take her into a group of other trans women, let's say she's going to the center in New York, or maybe a center, an LGBT center in New Jersey, she's going to a trans women's group, she may find that being Black and lesbian is what really is standing out and either privileging or oppressing her in that room. Is this all making sense so far?
Yes.
Yeah.
Great. So when we think about gender identity and gender identity development, a lot of the times we want to start very young. And we hear this a lot, right? There have been a lot of kid stories that have been popularized that are kids who, as early as 3 or 4 years of age, are saying that they identify as a gender other than the sex that they were assigned at birth. And there are many stories of this that the news tends to pick up on. This is not the only experience that people have. Some people identify as transgender as early as 3 to 4 years of age. The most recent research that I found said the average age of gender identity was about 8.3 years old. And then, in very staggering relief to this, the average disclosure to parents was 17 years old. So kids are living for about 9 years with the secret without telling. It's really sometimes that some younger kids talk sooner, and also some kids just don't become aware of their transgender identity until later. And so this can happen after puberty, it can happen in older age. There are many reasons why people would talk about their gender identity later on, but some people, it actually is just that they don't really experience their gender incongruence or their gender dysphoria until later. There's a very big difference, and one of the things that we use to talk about, whether or not kids really are truly transgender or really gender dysphoric, there's a very big difference between thinking, feeling, and knowing you are the other gender. So thinking like a girl, feeling like a girl, and knowing you're a girl, versus just wishing you were a girl. And you can see that in kids play a lot, that when young kids come into gender clinics, they will say, if they're transgender or non-binary, they'll say, I'm a girl, I want to be called this, I get very upset when I don't get called that, I want to dress like a girl, I don't want to wear the clothes of a boy, I have the feelings of a girl, I love playing with girls, and those are the kind of things that kids would typically express. A kid who is sort of experiencing some gender play, or is, maybe even experiencing questions around sexual orientation, may wish that they were the other gender because it might seem easier, for example, to be a girl who likes boys rather than a boy who likes boys, right? Does that distinction make sense?
Yes.
Great. Puberty is a big age at which kids identify and start feeling more distress around gender. And so one of the reasons is the anticipation of body changes, so anticipation of secondary sex characteristics that are developing, breasts, hips, testes, etc., hair in places where you haven't had it before. So some is the anticipation about that, and some of it is really just that starts happening. And so kids who have been able to be, for example, a tomboy before and have not developed yet, at puberty may start to feel some really greatly increased depression, anxiety, suicidality, or social withdrawal. When gender identity is what we call persistent, insistent, and consistent, meaning it doesn't go away, it causes a huge amount of distress, and it's consistent across contexts. So it's not just happening at home, it's happening at grandma's house, it's happening when I'm playing at the park, it's happening when I'm at school. It is very unlikely to change, and especially after age 14. So there's a lot of stuff in the news right now about people who have what people call desisted, or stopped being what people think of as stopping being transgender. That is a very complicated story, and a lot of times doesn't necessarily mean that they're not transgender, but it is very unlikely to change if people are, have started to experience puberty, are feeling acutely dysphoric, and fall into these sort of three categories. For adolescents in particular, because I know you are in an adolescent setting, there is a great study of 70 gender dysphoric adolescents who started to feel gender dysphoria around age 12 and started cross-hormone therapy or hormone replacement therapy at 16, who were then surveyed after age 18. So they had been on therapy for 2 years. Testosterone, and we'll talk about this again more, testosterone for trans males, estrogen for trans females. What they found after age 18, so 2 years later, is that their behavioral and emotional symptoms had really decreased, their general functioning had improved, and no adolescent in this study by De Vries et al., which is a group from the Netherlands, no adolescent withdrew from the study, so nobody stopped taking hormones or said that they regretted it. And another thing to know about adolescents who are disclosing their gender is that the male-female ratio is very close to 1-to-1. Even though we may see, stories that are more popularized about trans females, so individuals who are assigned male at birth who come out and, like Laverne Cox or Janet Mock, who identify as female. One of the reasons why we think that maybe we don't actually see as many trans males is that it's a little bit easier to pass as a tomboy for a while than it is to pass as a girl. And so these stories may just be more quieted. So one of the things that you really want to distinguish is whether or not people are experiencing gender nonconformity or gender incongruence versus gender dysphoria. And gender dysphoria is what we talk about when we're talking about people wanting access to hormones, wanting access to surgeries, so that it can relieve some of this distress that is caused by a discrepancy between a person's gender identity and that person's sex assigned at birth. So it is the consistent, insistent, and persistent qualification of this nagging thing that won't go away that is making you so unhappy. And it usually does make people unhappy, particularly if they're not affirmed. If people are in more affirming settings, they may not feel as much dysphoria because they may be able to explore a little more. But the dysphoria, the gender incongruence may still be there. There's a little bit of a difference between gender nonconformity or gender incongruence that isn't distressing, which is really when people feel like society doesn't let them express themselves in their gender the way that they want to. It may be too rigid, or there may be too many expectations on them to align with their gender in everything that they do, to do only boy things, to do only girl things, but they don't necessarily dislike being a boy or a girl. So that would just sort of be this incongruence, like society doesn't capture, these norms don't capture who I want to be in the world, but I'm okay with who I am. WPATH is the group that I spoke about earlier. These are the standards of care. They are free online. There is a broad application, and they give a very good introduction to all of the things that you are take into consideration when you're starting to provide transgender care. It is a long but great read, and I would recommend it for anyone if you have questions about care in general. These are just guidelines. They are not rules or regulations about how care should be done. Okay, so I'm going to talk a little bit about the minority stress model, which is what I alluded to before, that there may be, the minority stress model basically says that there is stress that people who hold minoritized identities experience due to a hostile environment and persistent discrimination and harassment, which increases poor mental health outcomes. This may be stress that people feel across a broad range of identities. The minority stress model was originally developed to talk about LGBT minority stress, but it's broadly applicable to other people who experience oppression and marginalization. The idea with this is that as it applies to transgender individuals, transgender non-binary individuals often experience high levels of minority stress. And this may be because of lack of access to care, lack of ability to pass as the gender that they know themselves to be, lack of ability to find a job or find familial support based on their gender identity. With the minority stress model, minority stress really is enacted across context. So it doesn't just have to be something that happens only when you're outside of your home. It can happen at home, it can happen at school, etc. It can happen anywhere. And a lot of the ways that we see it when we're working with adolescents is via this family response to people's gender identity. Even though there's been an important increase in visibility in transgender individuals, it has really been accompanied by greater experiences of discrimination and actually lessened public support, which may not be surprising. There have been a lot of transgender bans and a lot of laws that have come recently, both from our executive branch as well as other people who are writing laws and trying to pass them. These direct discriminatory practices really do make people feel very threatened because they are worried about having protections removed and not being safe. One thing that comes up a lot when you're talking with adolescents, when you're talking with trans individuals, if you get to talk to them more, people will talk about avoiding using a public restroom because they are afraid of confrontations or other problems they might experience. And this isn't just, a confrontation could be as little as, hey, I think you're in the wrong bathroom, to somebody saying, you can't be in this bathroom, you can't use it. So people actually try to not eat or drink at hours that will require them to use a public restroom in public later on. I had a lot of kids who would come and see me, and they would say, they would just be really thirsty. And I would say, why are you thirsty? And they said, I haven't had any water all day. I can only use the art teacher's bathroom at school. And in order to go use the bathroom, I have to go ask the front desk. And then everybody knows I have to pee and it's too embarrassing. And so I just don't drink water. But there are these, complications in a lot of different ways that we don't think of. There is a really great resource called the Movement Advancement Project. These state tallies by sexual orientation and gender identity are from their data. You can see that there have been both positive and negative things that have happened. We have seen an increase in bills to like bathroom bills, but we also have seen states like New York banning conversion therapy for minors. Are people aware of what conversion therapy is?
Yes.
Okay, so it is not banned universally. Conversion therapy is a largely, hugely disproven, harmful therapy that hopes to keep people from identifying as, any kind of sexual or gender minority. It does not work. It is now New York is trying to ban it just for minors, but it likely should be banned for everyone. Are there any questions about that?
No.
Okay, great. We've talked a little bit about distress at school. I'm not going to go through all of these. These are things that you can also look up. I'll provide you with a resource that you can look to when you're done with this if you want to look up more information. But adolescents in K through 12 really are harassed quite a bit and disciplined for being transgender, and oftentimes leave school. Youth marginalized for gender identity have much higher rates of all of the things we talked about: victimization, violence, homelessness, family rejection, but also suicide. So there are massive disparities in the suicide attempt rates of trans adolescents compared to their cisgender peers. So one of the things that really does make a huge difference with these negative outcomes is family support. So a big task of providers of therapy for transgender and non-binary individuals is to try to help parents come along and support the child in any way that they can, and or to find other sources of support like in the community or other places. You can see there's a large difference right here where it says attempted suicide. In one study from the Trans Pulse Project, people were reporting whether or not they had ever attempted suicide in their lifetime. 4% of individuals with supportive parents reported that. That's closer to the national average, whereas 57% of trans individuals with unsupportive parents reported a suicide attempt. So it's a very big concern. Depression rates are also much higher. Here's another study that talks about youth who believe whether or not they can be a happy LGBT adult. When family acceptance is high, for extremely accepting families, 92% of individuals believe they can be happy as they grow up. When family acceptance is low, only 35% of individuals report believing that they can be a happy adult. So this is a big concern, right? It's hard to be future leaning when you don't have any support in the moment. And it is a lot of the job of providers of trans care is to create a place to catch kids who aren't getting the support that they need. So it's really important what you do. There's a survey called the USTS, the United States Transgender Survey. It's the largest survey ever devoted to the lives and experiences of trans people in the US. They have 28,000 respondents. There is a New Jersey state report, so you can look and see how New Jersey did in comparison to national averages. And again, there are large reports of people experiencing serious psychological distress, attempted suicide in their lifetime, and attempted suicide in the past year. And you can see by comparison, these 39% compared to with 5% of the US population is a stark difference. So these providers of any kind of either medical or psychological care are really tasked with trying to hold people in a safer and more accepting place so that so that they can continue to live and try to get the affirming care they deserve. Just talking briefly about HIV status from the USTS, 53% of individuals knew that they were HIV negative. This is really important because if you look at other populations of individuals, not many people, these high rates of knowing that you're HIV negative are pretty uncommon. So what this speaks to is that the adult trans community is pretty up with testing and is more aware of their HIV status than other individuals. However, 1.4% of all of the 28,000 respondents were living with HIV, and that compared to the rate in the US population of 0.3% is very, very, it's multiplied by huge degrees. And so one of the reasons why we can think about that is, again, this piece about family rejection, where individuals who are less able to have a place to live, have food, support themselves, are often reporting that they have to turn to sex work. And in sex work, you have less negotiation of your ability to use protection. You may not have access to PrEP. There are also much higher rates of assault and sexual abuse and violence. So there are many pathways by which marginalization and lack of support and acceptance likely lead to this higher rate of HIV. I don't know, I know some about New Jersey. I live in New York. I look at you all across the water all the time. But thinking more about how New Jersey is impacted by HIV. This study, this is from AIDSview online, and it talks about people who are living with HIV in 2015 in New Jersey. So 35,636 individuals. They obviously did not divide this on a non-binary spectrum. So I would be really interested in finding out how this impacts your trans population. But what this speaks to is that it really is critical to help individuals know about how to prevent infection with HIV. One of the main reasons why is you can see this for New Jersey's estimate of HIV prevalence, the rate ratios by race and ethnicity, and you can see that and by gender, and you can see that as people experience more marginalization, they're more likely to be diagnosed with HIV. And so if you were to compound that by holding a gender identity, as we've seen, those rates are much higher nationally, you would likely see that in New Jersey as well. So education is key, as is access to PrEP and PEP. And lastly, those who were kicked out of their home were much more likely to be living with HIV. So 3.5%, which speaks to how people have to engage in economies that may increase their likelihood of being infected with HIV. All right. Gender affirming care is really critical, and this is sort of the biggest piece that we'll talk about as it relates to your site, because I'm understanding that you are building a program to provide more gender care to adolescents. And so one of the things you want to consider is that there are a lot of people who have paved the way for how not to do this in the past. One of the things that gets talked about a lot is this idea of therapists or medical providers in a gatekeeper role, meaning holding the gate shut so that trans folks can't get through. One of the ways that this has happened is that providers have asked people to identify in a very binary way in order to receive treatment or care. And that just, as we've seen in the way that people express their gender, that just isn't necessarily acceptable or a reasonable expectation for people's experience. And we know that denying access to care really increases distress. The current approaches that people use are much more gender affirming. You're acknowledging gender variation, just like we've talked about. You're supporting it, affirming it, and respecting it. And your treatment is evidence-based. That's where the WPATH standards of care comes in. And we know that gender identity affirmation combined with medical care and medical transition can really, for people who want it, can really reduce psychological distress. The other thing that providers are really tasked to do is to challenge their own held assumptions about identities and to treat transgender adolescents and their families or caregivers as experts in their own experience. So I think that one of the biggest missteps that I made as a provider early on is that I had, read a lot about trans experience, and I had, I was really enthusiastic about providing care, and I just would accidentally make missteps that were totally unintentional on my part and that I learned from, but that were hard for the person I was working with. I remember I was working with the first person I ever worked with. When they were presented to me by my supervisor, they said, "This is a trans female. She wants this and that, and she's coming in for trans care." And one day she was saying something about checking herself out in the mirror. And she said, "And I thought I looked good." And my response was, "Yeah, girl." And she goes, "Oh, I wasn't feeling that gender that day," and was really put off by my binary expectation of it. And because I was doing this for the first time, my binary expectation of her gender because I was doing this sort of for the first time, I just had to apologize. I was like, whoops, sorry, I made an assumption. What did you say in that moment? And just moved on. I think the second that you apologize and say that it's somebody else's responsibility for having, like, based on what they were wearing that day or what they were saying, you are putting it on them, and it's very hard it's putting the burden on them to make up for the mistake that you made. Just checking in. Okay. One of the big things that people can do before they access any kind of gender care is to socially transition if it's possible. And so with this, in a lot of individuals, this can refer to, growing their hair into a more feminine hairstyle or a more masculine hairstyle, wearing clothing that aligns with their gender, asking to use a name that's more aligned with their gender that they know themselves to use, and using different pronouns. These are not any kind of intervention that you have to make. It's something that people can be helped through. They shouldn't be required to do it at all, but it can make them feel much more affirmed if they're able to do it. So a lot of times with parents, we'll say, let's talk about helping your kiddo to socially transition at home, and then at school, you'll need to let school know that the correct name and pronouns to use, and that, this kiddo is going to be working through this so that they can be supported, so that they have allies at the school. I am mindful that we started a little bit late, so what I may do is just send you these links so that you all can actually spend time and watch these videos on your own. Does that sound okay? And then you can actually watch the whole thing. But this is a great video by a young trans girl who was actually featured on National Geographic. And she talks about how she's the scary transgender person that you heard about. And is sort of talking, you recognize her battle with having to face society's beliefs around her gender identity, but also you can really see her resilience and knowledge of herself, even at a young age. Does that sound okay if I send you these links so that people can watch?
Yeah, that'd be perfect.
Okay, I think that would probably be better. There we go. So let's talk a little bit about medical care. There are sort of 3 levels of medical care that people may or may not want to access. There is social transition, which can involve the things that we talked about with external presentation, longer hair, makeup, things like that, but it can also involve binders and gaps. It should not take a medical doctor to give someone, you don't have to have a prescription to buy a chest binder, which is a safer and healthier way for people to bind their breasts and to have the appearance of a flatter chest without a mastectomy. This is something that you should know about if you have patients coming to you and asking about what size binders to get. Oftentimes, patients will want to get smaller binders because they think that it'll make them appear flatter, but that can do some damage with their ability to breathe. So it can help to really be able to advise them to get the right size and help them measure. Pubertal blockers are different. These are medical intervention that is completely reversible, but basically staves off puberty for a period of time, so that if you have somebody who is either the family hasn't come along yet in supporting their gender, or they're feeling indecisive about how they want to identify and if they want access to testosterone, it can hold puberty in its place and keep people from developing the secondary sex characteristics or further developing them, and so reducing dysphoria. These are completely reversible. The only concern that I know of with these, there's some concerns related to surgery later on, but that information is still forthcoming about having enough tissue for surgery. Partially reversible are gender-affirming hormones, so testosterone, estrogen, and then spironolactone, that is the testosterone agonist. And then irreversible are surgeries. So irreversible in the way that if you get a mastectomy, yes, you could get breast implants later on, but you cannot regain your original breast tissue. We've talked a little bit about pubertal blockers and gender-affirming hormones. Gender-affirming hormones, the androgens, testosterone, and estrogen, can create physiological changes that look like the secondary sex characteristics of the gender with which somebody identifies. So they can be really important in helping somebody to feel and know and express their gender outwardly. There is a big movement with WPATH of trans and non-binary people asking for nothing to be decided about them without them. This really just does highlight that you need to be talking with people and not recommending care. Everybody's decision around blockers, around hormones, around physiological changes with surgery should be theirs. And it is up to them to provide the consent, them or their parents to provide the consent for them to get it. The therapist shouldn't be making those decisions for them. This is the other video I'm going to send you, which is a bunch of adolescents talking about their experiences with medical providers. It's really wonderful if you are working in a medical setting to listen to their voices of experience. They talk a lot about how in their care environment, sometimes they get misnamed or misgendered. The paperwork can be burdensome in that it's requiring them to select binary gender identities. There are no bathrooms. It's hard to complain. Some staff are educated, some aren't. So these are all things to think about. There's a really great resource as you build your program with, there's a PhD level nurse named Kimberly Aquaviva, who has created a checklist for people to go through in their setting to determine whether or not their care environment is LGBT affirming. And it can be really helpful when you're looking at some modifications you may need to make to your setting and providing affirming care so that people feel comfortable and safe coming back. I'm happy to provide that link if you would like that as well.
That would be great, thanks.
Okay, perfect. I'll send it along. So lastly, the thing I would like to talk about is providing sexual and reproductive health care. My understanding is that's something that you all do in your clinic, correct?
Yes.
Great. So one of the things, and this could be an ongoing conversation, I'm certainly not going to cover everything in the few minutes that I have left, but one of the things to be really critical about when you're providing care to trans individuals and to individuals who are non-binary is to really question your presumptions about sexuality. I worked at Planned Parenthood in Colorado for a couple of years prior to going back to grad school. And even at Planned Parenthood, you know, as however many, 8 years ago when I was working there, the forms and the services that we were providing were very binary, right? It was like a male body needs this and a female body needs this. And that just is something that you really have to disrupt as you're providing sexual and reproductive health care for trans individuals. And also considering other identities as well, making sure that your approach is intersectional. Affirming asexuality as well. A lot of people who are trans or non-binary identified, many may identify as asexual and may need the same kind of birth control that other people need, but you know, may not actually feel themselves to be sexual people. This is part of disrupting your own expectations around sexual orientation identity, and is something that you can do as well to make sure that you're providing care that is affirming of gender and sexual identities. Challenging the scripts around sexual identity and behavior and gender roles. One of the things that has come up quite a bit with patients in the past is that they will talk about having to go and get, you know, a gynecological exam or an annual exam and feeling really uncomfortable when the medical doctor is referring to their sex parts with the names that are typically used. It is one of the things that you can do to create a really affirming environment is to have people identify what they would like their sex parts to be called, and that can make them much more comfortable. There are many things you can do. This is just the tip of the iceberg. Talking about consent is really critical, and talking about when something isn't consensual. There's just such high rates of victimization and violence that being able to talk to people about non-consensual sexual behavior is critical to try to get them to care that they could need to improve symptoms. And talking about safer sex and safer sex tools, there's a guide from the Human Rights Campaign called Safer Sex for Trans Bodies that provides some really important and descriptive ways to have safer sex and to be resourceful about it for these bodies. That is it. That's your Whirlwind Trans 101. I'm so happy to answer questions. I'm available for another few minutes. I don't know if you all need to step off immediately, but I'm happy to answer any questions that you have.